name's Preetha Ali. I'm a colorectal surgeon here at Overlake, and I'm going to be talking about pelvic floor disorders as a total. So I'm not a urologist, but I am going to touch on the anterior compartment just a little bit, but our primary focus is going to be more on the posterior side. So in order to give you a good foundation, it's important to understand the anatomy as well. So we're first just going to talk about your pelvic floor. This is basically looking from the feet up. As you can see, you have your urethra, your vagina, and your rectum in sort of a line, but your pelvic floor itself is blanketed in a very complex network of muscular tissue. So that's important to kind of understand as we go through some of the disorders that we're going to be talking about. This is a side view of your pelvis, so imagine if your pelvis was cut in half. Like I said, I'm going to be focusing more on the rectum and the posterior side, but also what I wanted to point out here is that your pelvis itself is sort of, the very base of it is a large muscular floor. And this is a side view of your anus itself, because this is an important component of how pelvic floor functions. So we are going to be talking about your sphincter complex, specifically sort of the internal muscle and the external muscle. And finally, the last part of your pelvis that's also very important is how the nerves function with all the muscular tissue to give you a good functioning pelvis as a whole. So the first thing I wanted to talk about is prolapse of organs. So what does prolapse even mean? When we're talking about rectal prolapse, the rectum is the last part of your large intestine, and it can tend to fall from its normal position as the ligaments and the suspension of your pelvis starts to weaken over time. Now, what can cause that to weaken? So things that we talk about are both, not just the age itself, but also because naturally things weaken over time, especially with menopause and sort of the loss of our estrogen, but also damage to pelvic nerves, which can happen after childbirth, radiation to the pelvis, things like that can also start to weaken the muscle tissue as a whole. We also, things like chronic constipation and straining can weaken things after time, but also even just, certain disorders like diabetes or connective tissue disorders can lend to having more weak tissue, which is going to be, a theme that you're going to see throughout the course of this talk. Genes play a part, so hereditary factors are also a portion of prolapse, but also having multiple kids. It's very apt that I'm following after childbirth, but having multiple kids and sort of the constant tension on the pelvic floor does cause problems over time. So most important in diagnosis is evaluation. And I'm not going to go into too much detail because there's a lot of components that go into us evaluating the pelvic floor. Mostly a very thorough history and physical exam, which isn't always the most pleasant physical exam, but important for us to give a good understanding of what's happening. We have lots of imaging studies that check both the anatomy itself, but also the muscle tissue and the nerve tissue so that we can get a total view of what's actually happening. And finally, we work very closely with the urogynecologists and the gynecologists because oftentimes if there is something happening in the posterior compartment, there's something happening in the anterior compartment because the pelvis as a whole, like I said, is blanketed in this muscle tissue. So we do focus on both. When we talk about repairs or sort of what we do to treat prolapse, this is very multifold. So in certain patients, we go with a more abdominal approach where we have to essentially kind of resuspend the tissue up into the pelvis, but we reserve that mostly for healthier adults who are able to tolerate a very extensive surgery. It's done robotically or laparoscopically for the most part, but that doesn't mean that patients that are older can't have a repair. In that sense, we do more of a perineal repair where we approach it from below, where we essentially cut off the redundant tissue and tighten the anus so that we actually can reduce the risk of a recurrence occurring. Now, I'm sure some people have heard of a rectocele. I'm sure it's come up in some conversations at some point with gynecologists or urologists. But essentially, this is where just to break it down for you, it's essentially where the septum or the wall between the rectum and the vagina has also weakened over time because that's also muscular tissue. And that can, the rectum is a high pressure zone compared to the vagina. And so as time passes, the rectum can start to bulge into the vaginal canal as shown in the second picture here. Now, the symptoms of this can be pretty nonspecific. Some people will feel like a fullness in their vagina or even like a pelvic heaviness. Sometimes it can be even difficulty evacuating where you're straining or you're having to almost give yourself digital support of that posterior vaginal wall to be able to evacuate more completely. And sometimes it can even be painful intercourse, because of the bulging that occurs on the vaginal side, along with dryness that can contribute as well. Diagnosing a rectocele is mostly through clinical exam. We do some imaging studies, but we don't necessarily treat the imaging, we treat symptoms. So even if you have a moderate rectocele, but it's not necessarily causing you difficulty, we don't necessarily need to have a surgical repair. However, if it is large and you are having symptoms that are chronic, then we consider whether or not we need to do a transanal or a vaginal repair to be able to correct the rectocele itself. The last thing that I wanted to talk about not the last thing, one of the other things I wanted to talk about from a rectal standpoint is obstructed defecation. So this is not necessarily a surgical issue, but more a muscular issue. So when you look at this picture at rest, you have a muscle that basically kind of kinks off your rectum until it's socially acceptable for you to actually evacuate your rectum. Then you go ahead, and as your brain basically sends a signal to the muscle tissue to say, like, you know what, it's time to relax, to be able to straighten things out, and the muscle tissue actually relaxes to essentially straighten out your rectum and evacuate. Certain times this relaxation of this muscle, the puborectalis muscle specifically, doesn't always occur. And that can be where you're having difficulty actually completely evacuating your stool. So feeling like you're very full, or that incomplete evacuation. Sometimes you can even have seepage or overflow incontinence over time where because you're not evacuating, some of that finds its way out. So that can also be some of the symptoms that you'll see. Sometimes you'll just feel abdominal pain because you're backed up. You're not necessarily able to evacuate more completely. It's a pretty delayed diagnosis because we really do rule out everything else organic that could be happening. But I will say that one of the mainstays of treatment for this, which again, you're gonna hear about more in detail afterwards, after my talk, is physical therapy. We try to retrain some of those muscles to function better, recreate the feedback loops in a more functional way, by retraining the muscles and retraining the brain to say, you know what, time to relax, to be able to evacuate more completely. So the next thing I want to talk about is a much more sensitive topic. It's fecal incontinence. Most people don't necessarily want to talk about it, so it's fairly underreported. We think that the incidence is around 2 to 20%, though I think that's a very frank underestimate as to how much it's actually occurring. Nobody wants to talk about it, but it's a very common issue. A lot of times people who have urinary incontinence tend to have some fecal incontinence as well. And that's because, like I said, the compartment works together. So when we talk about incontinence, it's important to understand what actually goes into continence. So being able to actually hold your stool. That's a pretty complex issue, actually. We think it's very simple. It's just the muscle should work. But that's not necessarily the case. It's a synchrony of the muscle tissue, the nerve tissue, and how your pelvic floor as a whole functions together is what confers one's continence. So what can cause incontinence then? Injury to the sphincter complex itself. So as we talked about, you have an internal muscle and an external sphincter muscle. So if that gets damaged, sometimes through anorectal surgery or even obstetric trauma. So 3rd and 4th degree tears very commonly, not necessarily right after your childbirth, but even down the line as that muscle kind of atrophies or thins out with the repair, that can also lend to a weakening sphincter over time. Stroke or spinal cord injury, and even radiation to the lower pelvis, which tends to damage those nerves and muscles. Some medications like chemotherapy, antibiotics, even pain medication lend to this, bad diets, chronic constipation and diarrhea, and connective tissue disorders or diabetes disorders like that can also lend to fecal incontinence with time. So when we talk about management is pretty multifold. There's the conservative stuff. We want to make sure that we modify your diet accordingly to make your stools more normal. Medication modifications that are lending to this kind of incontinence, but also antidiarrheals and skincare are a portion of it. But we also have, and again, Kathy is going to be talking about this in a little bit, but physical therapy is a very important component of incontinence because we want to basically strengthen your pelvic floor as a whole, and it oftentimes sandwiches whatever surgical therapy that we do. So if we do sphincter repairs or if we have to do any sort of larger surgery, we always sort of sandwich that with physical therapy to give you the most optimal result. Now, some things that we can do for fecal incontinence are injectables. So anal cushions are essentially, actually your hemorrhoids, they tend to give you some anal cushions, but sometimes those can also thin out over time. And so we try to recreate these cushions by actually injecting things sort of right under that layer of the rectum itself that can give you a little bit more bulk to the anal canal. They are usually silicone or carbon beads, sometimes fat, sometimes even man-made materials. But it's a pretty simple office procedure, pretty minimal downtime. It's reserved for certain patients that I think will have the best result with this, but it is an option. The other things that we do, and I'm not sure if you can see this picture so clearly, but is we do direct muscle repairs to actually strengthen that sphincter. Now, the long-term results for this, over 5 years tends to be not so great because, again, as you're repairing muscle and you keep repairing muscle, it tends to atrophy over time. So the 5-year success rate of this is not as great as we would like it to be. So again, we reserve this in specific patients that have maybe specific conditions that would be the most apt for this kind of a repair. We also do artificial bowel sphincters. Now, we don't do that necessarily at this center. They're done usually at pretty specific centers, but we have devices that can be implanted that actually recreate your sphincter complex itself. And lastly, most people don't like to talk about this one, but a colostomy. And this can be actually fairly liberating for a lot of women. And what that means is that we actually bring up a piece of bowel to the abdominal wall, because most of the time with incontinence, it tends to really change one's daily activities. This at least will give you back your life, because you can you're able to predict what happens, and it's not in an area where you can't necessarily control the stool. So this is an option for certain people. Most of the time, it's one of our last resort options, but it is something that we can do. I wanted to talk a little bit about a newer technology that we have now for fecal incontinence. This has basically been approved since 2011, and it's what we call, it's essentially a sacral nerve stimulation, and it's essentially a pacemaker for the pelvic nerves. So what this does is that it was only recently approved for fecal incontinence because it's been used for urinary incontinence for years. And it was, we noticed, again, when patients had urinary incontinence issues that improved, their fecal incontinence got better also. We don't know the exact reason that it works so well, actually, other than the fact that it's stimulating the nerves that can create that sensory loop from the rectum to the brain and back. So this particular device is implanted into your sacrum. It's a very thin wire, almost spaghetti-like in nature, and it stimulates the nerve endings to send that sensory loop. There was a recent study that was done, I think in 2015, that showed of about 152 patients that had this device placed, almost 95% of them saw at least a greater than 50% improvement in the number of episodes. So in the right patient, this is a great device to be implanted. Now, I want to go over a little bit about the anterior compartment. Again, I am not a urologist, but I think it's important, when we're talking about the pelvis itself, to describe kind of the totality of it. So when we're talking about the anterior compartment, just as a reminder, this is where we're focusing on the bladder, the vagina, and the uterus, essentially. So urinary incontinence, it actually affects about 1/3 of the women in our country in the US, but it also has a lot of, it has pretty severe implications. It costs about $20 billion a year in just direct costs, but there's also the indirect costs, such as falls, fractures, nursing home care, sometimes increased caregiver burden, just with urinary incontinence alone. It can increase rates of depression, anxiety, loss of self-esteem. It can also even limit one's activity socially if it is a fairly severe problem. So it is something that is a big issue, in the US, and can be a major factor even in decisions for family members to want to put somebody else into a nursing home. Maybe they can't necessarily care for them at home. So it does have some pretty dramatic implications. When we talk about fecal incontinence itself, there's different types. So the first one is stress urinary incontinence. This is where you lose urine with coughing, sneezing, laughing, lifting groceries. That can happen usually from the sphincter defect in the urethra itself. So, when we talk about treatment for this, a lot of the treatment is to support that urethra. So sometimes that's done through behavioral modification, sometimes it's done through physical therapy, sometimes it's also done through even medications or mechanical devices like pessaries that can kind of prop everything up a little bit more. Also, we have surgical options like urethral injections or bulking agents to that urethra, or sling procedures that can be done. The other one is overflow incontinence. Overflow incontinence has to do with essentially the intrinsic muscle issues with the bladder itself. And that can be symptoms like urgency, frequency, going to the bathroom in the middle of the night often, or even incontinence. Now, this is, we don't know the exact cause for why this happens. And the treatment for this can be medications, physical therapy, but Botox Botox is not just used for wrinkles. We use it in the pelvis all the time. And it's because it really kind of helps that muscle from overreacting. We also use Botox in another form of overflow incontinence, and this is where you have kind of poor contractility of the muscle tissue itself, but Botox can even be an option for that. And then there's even just transient incontinence, right? So things with, issues with mobility or issues with cognition or dexterity can affect one's continence over time. And those are more supportive treatments more than anything, things like bedside commodes or having increased assistance. Now, I wanted to talk a few seconds about different just a few conditions that also occur in the anterior pelvic compartment. One of them is a cystocele. A cystocele is where the bladder itself falls from its normal position. So if you can see in the second picture, it's starting to bow into the vaginal canal. Usually it's more of an anterior wall issue in the vagina. There is uterine prolapse itself. This is where the suspensory ligaments get weak enough that the apex of the vagina will start to descend. People will feel kind of a bulge or even painful intercourse, even difficulty with sort of feeling that fullness all the time. There's vaginal wall prolapse, which tends to occur mostly after you've had a hysterectomy because that suspension is gone now. So now that apex starts to sag a little bit. And lastly, an enterocele. And an enterocele can occur with or without your uterus. It's not true that you don't have to have your uterus for an enterocele to occur. And this is where the small intestine, or that's what the entero part of this is, kind of descends into the pelvis and starts to push in. And sometimes people will feel bulging in their perineum or kind of fullness in the perineum. So just a quick plug, I wanted to talk quickly about colon rectal cancer screening. It is a fairly deficient part of our health maintenance. I think most people really don't want to get their colonoscopy done, but I'll tell you ladies, it is very important in your health maintenance, mostly because colon cancer is much more annoying than getting your colonoscopy done. So there's about a 5 to 6% risk of colon cancer in the general population. We found that colonoscopy is sort of our gold standard as a diagnostic and therapeutic tool to be able to reduce your risk. And that's because during colonoscopy, we actually remove the colon polyps which a small portion can go on to become colon cancer. So by removing them, we dramatically reduce your risk overall. So the prep can be frustrating. I get that. It's not a fun thing to do, but it's one day, your colonoscopy, you come in, it's kind of fun. You get medications that make you pretty loopy and sleepy until you don't really remember most of your scope anyways. But it's about a 45-minute long procedure. It's pretty quick. It is a good way for you to overall reduce your risk. Most screening guidelines right now start at age 50. There are some groups that are starting to recommend age 45. It's not caught on to insurance companies, and it's not a more widely accepted rate quite yet, but it is something that is probably going to change, I would say, over the course of the next 5 to 6 years, that our guidelines are going to change and reduce to age 45. So see your PCPs, come see us, whatever it is, just get your colon cancer screening done. All right.